Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Iqra Rafiq. I am going to present a study on the behalf of Dr. Sundar Saib. My topic of presentation is comparison of outcome of stoma refeeding versus no stoma refeeding in infants with enterostomy. There are several diseases in which small bowel enterostomy are indicated. Most common ones are necrotizing enterocolitis, small bowel atresia, and meconium ileus. Due to stoma formation, we encountered several complications like peristomal rash, high output stoma that lead to the dehydration, malnourishment, and electrolyte imbalance. After that, stoma prolapse and stomal stenosis. Stoma refeeding involves reintroducing the stoma effluent through the distal stoma. In this picture, you can see the catheter in the distal stoma and collected stoma effluent are infused in the distal stoma. The complete procedure is that after applying a stoma bag around the stoma, appropriate size Foley's catheter inserted in the distal stoma and collected content of 4 hours is infused in distal stoma over a period of 30 minutes. There are several benefits of stoma refeeding. It helps in intestinal adaptation by promoting mucosal growth and preventing atrophy of distal bowel. It helps to gain weight in shorter time of period, and it reduces the stoma complications like stomal stenosis, skin excoriation, and sepsis. The objective of our study is to compare the outcome in terms of weight gain in infants having small bowel enterostomy with or without stoma refeeding. It is randomized control trial done in the University of Child Health Sciences, the Children's Hospital, Lahore. Total duration is 6 months. Total 60 patients were included. Group A is assigned refeeding group and Group B is assigned without refeeding. It is non-probability consecutive sampling. We include patients with the age of 0 day to 1 year and all patients with the small bowel stoma, and we include both genders. We didn't include patients with a septicemia, with well-formed solid stool and multiple enterostomies. On discharge, we taught the parent about refeeding procedure and we noted following variables of age, weight at time of surgery, and diagnosis and hospital stay. We follow patient on OPD basis weekly and note for the weight gain. Results. In our study, most of the stomas were made in necrotizing enterocolitis, after that atresia. Our both groups were comparable in minimum age in days, and 2/3 of patients were male. We labeled adequate refeeding when more than 50% of stoma effluent are introduced in distal stoma and the frequency of refeeding is more than 3 times a day. Due to the poor compliance of parents, we subdivided our cases into 2 categories. First of all, inadequate refeeding and then adequate refeeding. We noted only 27% of patients get wean in inadequate refeeding and 72% of patients get wean in adequate refeeding, and there is a significant p-value of 0.003. There is a mean weight of 0.46 kg in refeeding group and 0.18 kg in non-refeeding group, and there is a significant p-value of 0.024. We noted that in refeeding group, 73% of patients gain weight and only 26% of patients lose weight. And while talking about the non-refeeding group, only 30% of patients gain weight and 53% of patients lose weight, and the weight of 16% of patients remains static. The significant value of 0.001. There are certain limitations. We are unable to monitor on daily basis, and we are unable to address mother difficulty regarding refeeding, and it is non-multicentric study. Take-home message is that we can prevent the waste flows associated with the stoma by introducing distal stoma refeeding in full spirit and by properly training our mothers about refeeding. In the end, I acknowledge the Department of Neonatology and Department of Anesthesia in the management of the patient.